This is a screencast just to talk through the assessment process for the FCP1 module. As you're aware, there's two parts to it, so we'll start off with the OSCE part of it. So the OSCE is a 40-minute inclusive OSCE. The timetable is already available to you on Blackboard, and just arrive 15 minutes prior to your scheduled time just to make sure that you've got time to be able to set up and get settled to the rooms, and we'll let you know the rooms close to the dates. It will be an unseen case study, and what we're looking for is you to be able to demonstrate thorough subjective history taking. And then for each case study, you'll then be asked to demonstrate a vascular component, a neurological component, an arthrogenic component, and then to be able to discuss further management strategies that you might utilise for this patient. Now, this shouldn't be very different to sort of what you do day to day in terms of your clinical practice. So what we're looking for is to make sure that you're happy enough in terms of your subjective history taking that you're able to go through systematically. We're looking for you to be able to at the minute. Is there anything over the counter? Is there anything prescribed? Are they taking any herbal medication? Thinking about do they have any allergies to anything at all? Um, any past medical history that you need to be aware of? And then thinking about social side of it as well. So, are they drinking any alcohol at all? Um, are they taking any recreational drugs? And then thinking about the condition, so any aggravating factors, easing factors, 24-hour pattern for the patient. And then we're looking for a sound, systematic, head to toe questioning of the patient. So any issues with head, any headaches or double vision, problems with speaking, swallowing, um, any problems with vision or hearing, thinking about the eyes, any visual disturbances, dizziness, blackouts, ear, nose, and throat. So any problems with um, swallowing, speaking, um, thinking about hearing, any auditory disturbances, any respiratory problems. So asthma, COPD, any shortness of breath at all, cardiac problems. So thinking about any diagnosed heart problems, any blood pressure issues, that kind of thing. Gastrointestinal problems. Do they have any known issues such as celiac? Have they got any issues with digestion, reflux, that kind of thing? Any genitourinary problems? So, have they got any issues with loss of bladder control at all, loss of bowel control, any blood in the urine that they've noticed? Thinking about sexual health, are there any issues with loss of sexual function, loss of sensation around the area? Any liver issues, kidney issues, any blood in the urine again? Thinking about any lower back pain, are they diagnosed any liver or kidney issues? Any neurological issues, any pins and needles, numbness, any gait disturbances, any musculoskeletal problems other than the one that they've come in with, so any alternative joint replacements or alternative ongoing treatment that they might be under the care of, or hypermobility problems, and then any psychological issues, so anything going on in relation to workplace or anxiety, depression, any issues with PTSD around the reason why they've come in today. So we're looking for a systematic approach to the patient for every single patient, and approach to the OSCE. There are case studies up on the Blackboard site, but what we'll do when we next see you next week is we'll go through and we'll practice the OSCE. So don't worry too much about that. And then, so the last part of that would be thinking about the tests that we might ask you to perform. And this isn't an exhaustive list, but it's some of the things that you might want to practice between now and the assessment. So the vascular components are listed below, neurological aspects, arthrogenic, And then additionally, to be able to discuss elements of onward referral, further investigations or MDT involvement, and to be able to justify these with relevant literature. You don't need to be able to reel off lots and lots of literature in relation to this, but it's to be able to refer to guidelines or trust guidelines, or perhaps relevant literature that you've read recently that might support your decision for a particular test or a particular onwards referral. And then thinking about the case study. So it's a 3,500 word case study consisting of 2 parts. And if you want to, you can combine these into one. So you can combine the whole job lot into 3,500 words, as long as you answer in part A and part B within that. You don't have to completely separate them. That's up to you. So we're looking for a complex case study discussing the management of the patient, thinking about additional tests, analysis and assessment of the patient. So you should be discussing what you might be ordering test-wise. You're thinking about how you might analyse the patient a little bit further, and also what assessment techniques you might be using or utilising to help manage the patient. So this is where the critical analysis of the literature comes in. So we want you to be able to justify your clinical decisions and your forward planning in relation to your case study, demonstrating advanced communication and an ability to link your clinical information with diagnostic findings and the need for further ongoing tests and recommendations for further management. So we're thinking about how you might subjectively assess the patient within the OSCE, and then touching on objective assessment of the patient for some of the more advanced level analysis and assessment. And then within this case today, we're looking at you being able to discuss and justify management. So making sure you've got a robust method of being able to sift through literature and to be able to clinically reason and justify why you would do what you would do with that patient. So we're talking more around the management side of things. And then the part B aspect of the case study. Again, you can integrate this doesn't matter, but you're looking at around a 2,500 to 1,000 word split between A and B. Is the reflective account of your case study, and you need to be able to critically reflect on your impact as the clinician. So it would be really useful for you to be able to use a reflective tool, and again this is very personal and subjective to yourself and your clinical environment, so it's always worth discussing what clinical tool for reflection you might use, and then thinking about how your service is geared towards management of the patient group and outline future pathway developments within your assessment if necessary. So this is a self-reflection and a reflection on your clinical environment, and something that you should be able to utilise within your clinical environment to inform patient practice and to improve the services that your local areas provide. So some guidance towards this or questions that you might want to answer throughout are outlined just here. So part A and part B. What are your patient's beliefs? How am I going to talk through difficult barriers in communication? How am I going to break bad news? What tests might I order and why? What tests won't I order and why won't I do that? What evidence is there to support my decision-making process? And what other margins are there in the diagnostic tests that I've used? And is this considered in your approach, or does this lead you to an alternative route? So thinking about some of the imaging diagnostic errors or some of the prescribing issues. So if it's not working prescribing wise, how are you going to escalate that? Is the current management plan appropriate, and are you going to change it? Are you going to make a difference? Are you going to deprescribe or prescribe further, or refer to somebody who can prescribe? And what impact does different models of clinical reasoning have on the patient care pathway? And how does this have an impact on your management of patients and on your practice? And thinking about your differential diagnosis. So how do you know it is that? How do you know it isn't that? How are you ruling things out? What kind of clinical reasoning tools are you using within your practice day to day? And then part B, how are you justifying your decision? Is the quality of the evidence available appropriate to justify your clinical reasoning pathway? Are there any alternatives you could have used? Did I have a bias or ethical issues? How would I manage a similar patient again? What evidence is there for this? What impact does the diagnostic uncertainty have on the patient, on us, on the NHS, on our profession? What communication skills do I need to utilise? And what is the evidence behind this that I'm taking, the approach that I'm taking? And what ultimately does the evidence say? Does it support your reasoning? Does it challenge your reasoning? Again, this is not an exhaustive list. This is not something that you have to include within 3,500 words. 3,500 words will be used up incredibly quickly when you start sort of going into a complex case study and getting down to the bare bones of it. So it's making sure that you're coherent, you're to the point, and that you're getting your point across. Now, we do have a drop-in session available next Thursday, so the 18th, where we can discuss the written piece, and we can I can answer any questions that you need to. And then on the Tuesday, we will practice the OSCE repeatedly through different case studies, just to make sure that you're happy with that. And then we will have a formative assessment. So the formative assessment for the OSCE, we will just individually go through the assessment process on the Tuesday next week, just so that you are happy with the process, you're happy with the format for the OSCE. Now, the written piece, the formative assessment, so I'm going to say that 500 words, I'm happy to have a look over 500 words for each of you. And if you get that to me via email by 5 p.m. on the 26th of November, I will then get that back to you over the weekend by the 29th. So if you do want some feedback on your work that you've done so far, if you get that to me by the 29th, I will have a look at that, mark that, and then send that back to you with some feedback if there's anything that you're unsure of. I hope that's been helpful. I will see you next Tuesday. Take care.